students, good day to all of you. This is Dr. BK for you, and today I will be discussing about the scalp. So the learning objectives for today with regard to scalp will be the general introduction about the scalp, then the description of the various layers of the scalp, then more importantly the blood supply and the nerves of the scalp, then applied aspects. So after the scalp, I will also be discussing about the cervical vertebra. Now first let us try to understand what is scalp. Scalp is actually the soft tissue which is present on top of the skull or on top of the calvaria of the skull. You can call it even the vault. So the skull cap is called as the calvaria. Okay. Now these soft tissues are actually present in the form of 5 layers. But before that, what is the extension of the scalp? So anteriorly it extends up to the supraorbital margin, and posteriorly up to the external occipital protuberance and the superior nuchal line. Okay. So since it is extension into up to the supraorbital margin, there is of course an overlap of the region of the scalp and your face. The forehead region belongs to both the scalp as well as your face region. So posteriorly, external occipital protuberance in the midline and superior nuchal lines on the either side. Laterally, it also extends up to the zygomatic arch. So above the zygomatic arch, here you also have a temporal region. You have the temporal fossa covered with the temporal fascia. So the scalp merges, passes superficial to that temporal fossa, and then what happens is it extends up to the zygomatic arch. So these are the extensions of the scalp anteriorly, posteriorly and also laterally. So here a dissection of the layers of the scalp you can see here, right, starting from the scalp. The name itself is a mnemonic of the 5 layers. The uppermost layer is the outermost layer is the skin. Deep to the skin, what you have is the connective tissue, or you can also call it as the subcutaneous tissue, which is a fibro. Actually, it is actually a fibro-connective tissue. You have a little amount of fat, and you also have some fibrous tissue in it. Fibroelastic tissue. Then aponeurosis. You have an aponeurosis. So you all know that aponeurosis is nothing but a flattening sheet of the tendon, okay, which is actually called as the epicranial aponeurosis or the gallia aponeurotica. Then loose areolar tissue. You have the loose areolar tissue in the 4th layer, and 5th layer is the outer covering of the bone of the skull, which is the periosteum or the pericranium. So these are the 5 layers. Now it is very difficult to appreciate all these 5 layers, because when we actually reflect the skin, the first 3 layers comes along with the skin itself. So the first 3 layers are very much adhered. That means that connective tissue actually anchors the skin above and also the aponeurosis below. Okay. So that is the 5 layers of the scalp. Here deep to the cranium, you are also able to see the dura mater. Okay. Then followed by that you see the arachnoid pia, and then you are able to see the brain substance. So above the skull, these 5 layers actually form the scalp. The 5 layers, which are nothing but the mnemonic of these 5 layers. So as I told you, the first three layers are difficult to separate and move as one layer. And in case of avulsion of the scalp avulsion is when these three layers are stripped off. That is actually called as the avulsion of the scalp. So we will try to actually understand each and every layer. The first layer is actually the skin. So if you look at the skin, so it is a hairy skin, so it is a thin skin only, but at certain regions it is thick, especially posteriorly. The occipital region is thick. Then abundant of hair follicles. So it is a hairy skin, abundant of hair follicles. So thick distribution of hair in our body in the scalp. So around 1,20,000 hair follicles are actually present. And we tend to lose actually 50 to 100 of these hair follicles or hair daily basis, and it is replaced. Okay, and it depends upon the age, sex, your hormonal levels, nutrition, all these factors, and genetic disposition is also, the genetic factor is also involved in the distribution of the hair follicles. So great concentration of the hair in the skin, and it has also got sebaceous and sweat glands. So sebaceous glands are also present, which mainly what happens, lubricate your hair follicles, and also the sweat glands are also present. So when the ducts of these glands are blocked, it is actually called as the sebaceous cyst. Okay, so due to obstruction of the ducts of this gland, very common in the skin of the scalp, sebaceous cyst, and the sebaceous cyst is also very painful because the skin is very tightly adhered to the connective tissue. Then, so loss of hair, this is actually called as the hairline, which is variable from person to person, and the receding is hairline in the forehead is actually called as the male type of baldness. It is mainly due to the circulating androgens. So if there is a lot of androgens, circulating androgens in the blood, then they are prone for baldness, male type of baldness. And this male type of baldness, not only with the androgens, of course there is again a genetic predisposing factor. So naturally what happens, it runs in the family. Apart from that, other cases of hair fall might be due to any conditions, dermatological conditions, infections, or your nutritional status, or if you are not properly hydrated, okay, or some hormonal imbalance, or some diseases. In certain diseases we tend to lose hair. So all these factors. Apart from that, if you exclude all these factors, then the receding hairline is because of, in case of males, it is due to the circulating androgens. That is why it is called as male type of baldness. The next layer of the scalp is the connective tissue layer. So definitely it is a subcutaneous tissue. So below the skin, variable amount of fat is actually present in the subcutaneous tissue, and the nerves and the vessels of the scalp are actually present. Especially the blood vessels are present in the subcutaneous that tissue of the scalp. Deep to skin, you see some amount of fat is also there, and some amount of fibers are also present. Fibrous tissue is also present. So the 5 layers, deep to the skin, subcutaneous fat, and this connective tissue consists of the blood vessels. So they actually, the blood vessels are run in a centripetal direction. So that means from the periphery, they are actually ascending to the center. They are running towards the center of the head. So that is why to improve the circulations, what happens is the massage to the scalp should be given from lower to above. So from below to above, what happens, we should start massaging the scalp. So from forehead you go to the top of the skull, then from above the ear you go to the top of the skull, and so on. These blood vessels they are firmly adherent to this connective tissue layer. So the wall of the vessel is actually stuck to this connective tissue layer. So because of this, what happens is, if there is a laceration or cut in the scalp, the connective tissue, then it bleeds profusely. So wounds of the scalp, they bleed profusely. And not only that, they gape. So gaping is actually creating a wide cut. So they gape because of this nature of the connective tissue to which the blood vessels are adhered. So they bleed profusely because the walls of the blood vessel cannot retract and close after some time. So it has to be arrested. Okay, so that is one of the reasons they bleed profusely. But wounds of the scalp, they have a very great healing capacity. So the wounds of the scalp have a very great healing capacity because of the rich blood supply. So anywhere we have rich blood supply, what happens? It heals very fast. It gives rich vascularity. And again, edema, collection of these blood, especially in the connective tissue layer. Edema is mostly, if it is a small hematoma due to injury or something, it is localized. Okay, and very painful because again of the unyielding nature. It is not very serious if there is any extracranial hematoma in the connective tissue layer. Okay, small hematomas, they are localized, they are not generalized, they don't spread, and it is very painful because of the unyielding nature, even though the hematoma is small. The next layer of the scalp deep to the connective tissue layer is the aponeurosis, which we call it as the epicranial aponeurosis or the Gallia aponeurotica. So, any aponeurosis consists of dense collagen fibers. Posteriorly, if you look, the aponeurosis is very broad and it is attached to the mainly to the highest nuchal line and extends even to the external occipital protuberance. So in between the two occipital bellies, so you see the aponeurosis and also you see the muscle of the scalp, occipitofrontalis muscle. Between the two occipital bellies, it gets inserted into the external occipital protuberance, and here it is very broad. Okay. Whereas anteriorly between the two frontal bellies, it shows or it sends a very thin or narrow extension, and it does not have any bony attachment. It merges with the subcutaneous tissue. Okay, so it merges with the subcutaneous tissue, and the extension anteriorly is very narrow. Laterally, if you look at it, the Gallia aponeurotica, what happens is actually covers over the temporal region. So that is the temporal fossa with the temporalis muscle, and that will be covered by a temporal fascia, is a deep fascia. So it passes above the temporal fascia to get attached to the zygomatic arch, your Gallia aponeurotica. Okay. And sometimes it might also give origin to a variable muscle, temporoparietalis muscle. Okay. Apart from the frontal belly and occipital belly, sometimes you have a temporoparietalis muscle through which the auricle can be moved. But most of our auricular muscles, that is your auricularis anterior, auricularis superior, and auricularis posterior, they are all vestigial muscles in humans. Okay. So, the wounds, if gape, mainly it is due to the transverse cut of the aponeurosis, not a longitudinal cut. Longitudinal cut don't allow the wounds to gape or open widely, but a transverse cut actually makes the wound cut widely, especially if it is taking place deep to the connective tissue. So the connective tissue, the aponeurotic layer also has two muscles which is inserting into the aponeurosis, the occipitofrontalis muscle. As I told you, it has got two bellies. The occipital belly arises from the lateral half of the superior nuchal line. Okay, and then it is inserted into the Gallia aponeurotica. The frontal belly arises again, no bony attachment. from the skin of the forehead, subcutaneous tissue, and the medialmost fibers they intermingle with the procerus, okay, and the intermediate fibers with the corrugator supercilii, and the latermost fibers they intermingle with the orbicularis oculi. Okay, so these fibers intermingle with the procerus, corrugator supercilii, and the orbicularis oculi. So it is inserted into the skin. There is no bony attachment for the frontal belly, and posteriorly it is getting inserted into the galea aponeurotica, anterior part of the galea aponeurotica. When this belly acting from above, if this contracts from above, it will produce transverse wrinkles of the forehead. Okay, and both the bellies when they act together, what happens? They move the scalp, the front and below. You can see that your skin of the scalp sliding forwards and backwards. That is the action of the occipitofrontalis muscle. Alternatively, when the frontal belly and the occipital belly when they contract. Apart from that, the frontal belly alone contracts. They produce transverse wrinkles, transverse lines on the forehead. The frontal belly is actually supplied with the temporal branch of facial nerve, and whereas the occipital belly is supplied by the posterior auricular branch of the facial nerve. So whether it is the temporal branch or the posterior auricular branch, the facial nerve, it supplies this occipitofrontalis muscle. The next layer of the scalp is the layer of the loose areolar tissue. So it is actually a potential space, because the first three layers, that is your skin, your connective tissue, and the galea aponeurotica, are adherent to each other as single layer, these three layers. But below that, you have the potential layer. It is made up of loose areolar tissue, and mainly the emissary veins are actually present in this layer. Okay, so because of this loose tissue, they are first three layers, they slide freely, and as I told you, mainly the emissary veins are present in this fourth layer. So in the scalp, you have the parietal emissary veins, and then you have the diploic emissary veins. Sorry, the mastoid emissary veins. Okay, so these emissary veins, what happens is their main function is they connect the veins of the scalp with the intracranial neural venous sinuses. So here you are able to see one triangular space filled with venous blood, that is the superior sagittal sinus. And these flower-like expansion, you are able to see they are nothing but the arachnoid villi. Okay, so through which the cerebrospinal fluid actually is drained into these venous sinuses. So these neural venous sinuses and the veins of the scalp are actually connected by the emissary veins. So by any intracranial pressure, what happens will be balanced by these emissary veins, through which this pressure is transmitted to the extracranial veins of the scalp. So that is the main function of this, and they are valveless. But critically, this layer is very, very important, because any infections or wounds of the scalp, especially in the fourth layer, what happens is infections might be transferred from the extracranial veins via these emissary veins to the intracranial venous sinuses, and that might lead to thrombosis. Okay? So that might lead to the intracranial venous thrombosis because of the emissary vein. So that is why the fourth layer is actually called as the dangerous layer of the scalp, because infections from the scalp, what happens is, can actually transmitted via the emissary veins into the intracranial venous sinuses. Okay, and here you are able to see, as I told you, the bone of the vault of the skull has got outer table and inner table, and this porous tissue is actually called as the diplo, which is drained by the diploic veins. So again, the diploic veins might go and drain into the extracranial venous sinuses, or sometimes extracranial veins, or sometimes they might go and drain into the intracranial venous sinuses. So the fourth layer is actually considered as the dangerous layer of the scalp. The next layer is the periosteum, so which is a very loose layer covering the outer surface of the bone. It is also called as the pericranium. It is only tightly adhered at the region of the sutures, where the sutures are present. It is actually tightly fixed, and thereby along the sutures it is also continuous with the endosteum of the scalp. So the endosteum is mainly formed by the dura mater. Okay, so the endosteum is mainly formed by the dura mater of the brain. So the dura is inside the skull is made up of two layers. You have an endosteal layer, and then you have the meningeal layer. Endosteal layer is closely approximated to the bone, whereas the meningeal layer actually is approximated to the brain substance. Okay. So this what happens is the pericranium has poor osteogenic potential. So usually periosteum, the deeper layer, what happens is supplies the reserve cells for the bone growth. But here what happens is a very poor osteogenic potential. Not only that, any collection of fluid between the bone and the periosteum, what happens is it assumes the shape of the bone. So beneath this layer produce a localized swelling, because at certain parts at the periphery of the bone, this periosteum is tightly adhered to the sutures. So naturally that swelling might assume the shape of the bone. So that is about the fifth layer of scalp, which is the pericranium. So now we will come to the blood vessels of the scalp, mainly the arterial supply. So each half of the scalp is mainly supplied by 5 arteries. So totally 10 arteries supply the scalp, or you can call it as, or you can also tell it as 5 sets of arteries supply the scalp. So they can be divided in front of the auricle and behind the auricle. So in front of the auricle you have supraorbital and supratrochlear arteries. Supratrochlear artery and supraorbital artery. So these two arteries mainly supply the forehead region and also the anterior part of the scalp. They both are branches from ophthalmic division of internal carotid artery, supratrochlear and supraorbital. Supratrochlear is medial, supraorbital is lateral, which emerges from the supraorbital foramen of the skull. They are branches of the ophthalmic division of internal carotid artery. Behind the auricle, it is mainly supplied by the posterior auricular artery. Okay. And the one more is the occipital artery. Okay. So you have the occipital artery. So in front of the auricle you have supraorbital, supratrochlear, and one more artery is the superficial temporal artery, which is a branch of external carotid artery. Behind the auricle, two arteries, one is the posterior auricular and other one is the occipital arteries. So 3 arteries in front, 2 arteries behind. The first 2 are branches of the ophthalmic division of internal carotid artery. The remaining 3 are branches of the external carotid artery. So actually there is an anastomosis between the internal and external carotid system of arteries in the scalp. Next, coming to the venous drainage of the scalp. So mainly it drains into internal jugular vein, external jugular vein, and partly into the suboccipital venous plexus. So how actually it drains to the internal jugular vein is supraorbital and supratrochlear vein forms the facial vein. Supraorbital and supratrochlear vein forms the angular vein, which actually continues as the facial vein. So this facial vein joins with the anterior division of retromandibular vein. So this retromandibular vein is actually formed by the union of the superficial temporal vein and the maxillary vein. Superficial temporal vein and maxillary vein join to form the retromandibular vein within the parotid gland. This retromandibular vein divides into anterior division and the posterior division. Anterior division of retromandibular vein joins with the facial vein to form the common facial vein. This is the common facial vein which drains into the internal jugular vein. Okay, so supraorbital and supratrochlear forming the facial vein joining with anterior division of retromandibular forming common facial vein to drain into the internal jugular vein. Now, how actually drains to the external jugular vein is posterior auricular vein. This is the posterior auricular vein joins with the posterior division of retromandibular vein, and thereby they drain into the external jugular vein. Okay. Now, apart from this, you have the occipital vein that actually drains into the suboccipital venous plexus. Okay. So, occipital vein, they might drain into the suboccipital venous plexus, or sometimes it might also drain into the internal jugular vein. So, that is about the venous drainage of the scalp. Lymphatics, they mainly drain into preauricular lymph nodes in front of the auricle. So, that is what is called as preauricular lymph nodes or parotid lymph nodes. Then, postauricular lymph nodes, you have the mastoid lymph nodes. Then, apart from that, submandibular lymph nodes also drain the scalp. Okay. So, preauricular lymph nodes, postauricular or mastoid lymph nodes, and then more posteriorly have the occipital nodes, and submandibular nodes also drain the part of the scalp, submandibular lymph nodes. Next, coming to the nerves of the scalp. So, the nerves of the scalp, again you have 10 nerves for each half of the scalp. That is, right half it is supplied by 10 nerves, left half is supplied by the 10 nerves. So, 10 pairs of nerves supply the whole of the scalp. Of the 10 pairs, 5 actually seen in front of the auricle and 5 behind the auricle. Okay. So, 5 nerves for each of the half of the scalp, 5 nerves in front of the auricle, 5 nerves behind the auricle. Of the 5 nerves, 4 are sensory and actually one is the motor nerve. 4 sensory and 1 motor in front of the auricle. Same way behind the auricle also 4 sensory and 1 motor. So, in front of the auricle, the 4 sensory nerves are supratrochlear and supraorbital nerves. Then you have the zygomatico-temporal nerve, and then you have the auriculotemporal nerve. 4 nerves: supratrochlear, supraorbital, zygomatico-temporal, and auriculotemporal nerve. The first 2 are branches from ophthalmic division of trigeminal. The next one is actually branch from the maxillary division of trigeminal. Auriculotemporal is from the mandibular division of trigeminal. So, in front of the auricle, the sensory nerves are mainly from the branches of the trigeminal nerve. The one motor nerve is the temporal branch of facial nerve. Okay, which actually supplies your frontal belly of occipitofrontalis. Temporal branch of facial nerve supplies the frontal belly of occipitofrontalis muscle, which is the motor nerve. Now, coming to the nerves, so here you are able to see supratrochlear, supraorbital, zygomatico-temporal, auriculotemporal nerve. Behind the auricle, from medial to lateral, again 4 sensory and 1 motor nerve. The 4 sensory are great auricular nerve, C2, C3, again from the cervical plexus. Then you have the lesser occipital nerve, C2. Then you have the greater occipital nerve, and more medial you have the third occipital nerve. So, these 4 from lateral to medial, as you go from the auricle to the external occipital protuberance, the 4 sensory nerves are mainly the great auricle, lesser occipital, greater occipital, and then the third occipital nerve. The one motor nerve is the posterior auricular branch of facial nerve. This supplies the occipital belly of the occipitofrontalis muscle. So, 10 nerves, 5 in front and 5 behind. Of the 5 in front of the auricle, 4 sensory, they are branches from the trigeminal nerve. and one motor which is from the facial nerve. Behind the auricle again 4 sensory, they are from the cervical plexus, and one motor nerve which is the branch from the facial nerve. So coming to the clinical aspects. So what is black eye? Mainly what happens is deep to the third layer, if there is a collection of blood or fluid, mainly the layer of the emissary veins, fourth layer, loose areolar tissue, because there is no body attachment of the frontal belly of occipitofrontalis muscle. So this edema or the fluid, not the edema, the fluid collection might come and settle around the eye, and that is actually called as the black eye. And hematomas, if it is produced, so the hematoma might be subgaleal cephalohematoma, okay, deep to the gallia apodeurotica, or sometimes it might be deep to the periosteum, or it might be subdural or epidural. So subdural hematoma is deep to the dura mater, or epidural hematoma is actually between the root and the dura mater. So these are all taking place in the fractures of the skull. Subdural hematoma, epidural hematoma, mainly in the fractures of the skull. Now what happens in case of a fracture of the skull? Any hematoma, whether it is subdural or epidural, the blood first tends to collect extracranially, so outside the skull, deep to the gallia apodeurotica. So once this space is filled, only then what happens is the blood tends to collect deep to the skull. Okay, so that is actually called as the safety valve hematoma, because it actually buys some time before the hematoma collects within the skull and compresses the brain substance. So first the blood tends to ooze out through the fracture, and it tends to collect in the subgaleal region deep to the gallia apodeurotica. And only after this space is filled, then what happens, the hematoma will tend to get blood tends to get collected deep to the skull, whether it is above the dura or actually deep to the dura mater, and thereby compression takes place. That is actually called a safety valve hematoma. Caput succedaneum is a temporary swollen condition in neonates. Okay. So temporary swollen condition not actually occurs in all the neonates, but sometimes when the head passes through the birth canal during labor, so it might produce a temporary edematous condition, localized edema, and that usually resolves after a few days. So that is not a serious condition. So with this, I have completed the scalp. So I would also like to discuss certain aspects about the cervical vertebra. Totally, there are 7 cervical vertebra in the neck. They are numbered from 1 to 7. And how do you identify the cervical vertebra? You see the foramen in the transverse process, which is called as presence of foramen transversorium. So that is the very classical distinguishing feature, salient feature of the cervical vertebra. So you identify the vertebra when you see foramens on either side. In the transverse process, you see a foramen, then you can very well tell it is a cervical vertebra. So all these 7 cervical vertebra will have this foramen transversorium, but very rarely it might be absent in the 7th cervical vertebra. So of the 7, the first, second and the 7th are atypical, whereas the 3rd, 4th, 5th and the 6th are actually typical cervical vertebra. So typical is 3rd to 6th. The first one, second one and 7th one is the atypical vertebra. So what are the features of a typical cervical vertebra? The body is actually small and they are transversely oval. Okay, the body is small and transversely oval. That is one big thing you come across. Then the next thing is, if you look at the spine, it is actually small spine and bifid, and downturn. So you can able to see the tip of the spine is split. So that is why you call it as a bifid spine. Then when compared to the body, this vertebral foramen or the vertebral canal, you can call it as, it is large and triangular. Why it is large? Because most of the nerves of the spinal cord, the neural structures, they are still not distributed. Slowly what happens is it gets distributed as it passes to the cervical, from there to the thoracic lumbar region. At same way what happens from the lower part, even the ascending tracts, they tend to add from the lumbar region, thoracic and cervical region. What happens? All the ascending tracts are present, and the lower cervical part of the spinal cord, from their nerves also goes to inner vein upper limb, cervical enlargement. So for all these reasons, you can see the vertebral foramen or the canal is large and it is triangular in shape. Okay, so the spine is bifid. Pedicle arises from the middle of the body. So halfway, exactly from the upper and lower end, from the middle of the body, it actually arises and passes backwards. So because of that, the superior vertebral notch and the inferior vertebral notch both are conspicuous. So that means it is well marked. You can see a very marked notch superiorly as well as the inferiorly, which transmits the corresponding cervical spinal nerves. So lamina, these two are actually the lamina. They are thin and they are directed backwards and medially. The two lamina fuse to form the spine, which is very short spine, and it is a bifid spine. Again, a very classical distinguishing feature of the identification feature of the cervical vertebra. Superior articular process is flat and directed backwards and upwards, whereas the inferior articular process will be directed actually forwards, okay, and downwards. So both are reciprocal to each other, the superior articular facets and the inferior articular facets. Okay, faces actually, it's not backwards, it is actually forwards and downwards. So transverse process directed laterally, and you are able to see an anterior root and a posterior root, transverse process. Then you are able to see a tubercle and the anterior tubercle and the posterior tubercle. So two roots, two tubercles, and then these are actually joined by the costotransverse bar. Okay, they are actually joined by the costotransverse bar. So the anterior root, anterior tubercle, costotransverse bar and the posterior tubercle, they all belong to the costal element, whereas the original transverse element is only the posterior root. They are the reduced costal elements. If the costal elements is enlarged, which you can see in case of the thoracic vertebra, they will form the ribs. Okay. So so the foramen transversorium is actually present between the anterior root and the posterior root and the anterior posterior tubercles, and that is the costotransverse bar. Okay. Now the anterior tubercle of C6 vertebra alone is very prominent, and you call it as the carotid tubercle, against which the carotid artery, the internal carotid artery, can be actually compressed. So that is one feature of the C6 vertebra. Apart from that, it bears all the salient features of the typical cervical vertebra. C6 alone, the anterior tubercle is prominent, and it is actually called as the carotid tubercle. So the identification points for a typical cervical vertebra: presence of foramen transversorium, large triangular vertebral foramen, bifid spine. So these three things you should mainly remember. Next, coming to the atypical vertebra, the first cervical vertebra, also called as the atlas. So atlas, it is called as atlas because it bears the whole skull on top of it. So that is why it is actually called as the atlas vertebra. It is atypical vertebra. In what ways it is atypical? First of all, there is no body. So the centrum of the body is absent. Instead, it has two lateral bars. Okay. So it has a lateral bars. Posteriorly, again, spine not absent. Sorry, absent. No bifid spine. It is very much absent. And the two lateral bars are connected in front by the anterior arch and by the posterior arch. The spines of all cervical vertebra mainly gives attachment to the ligamentum UK. So that is the anterior arch and the posterior arch, and you see the two lateral bars. So the two lateral bars again has a superior articular facet. The lateral bars above has an articular facet which is bean shaped or PP shaped, and it is deeply concave. So this will receive the occipital condyles mainly, which is forming the atlanto-occipital joint. So these lateral bars, I told you the superior articular facet is kidney shaped, whereas the inferior articular facet is round. Then they are connected by an anterior arch of the atlas, which is very short, which bears an anterior tubercle, and the inner aspect of the arch you see a facet for articulation of the dens. So dens is actually from the second cervical vertebra. It is believed the centrum of the first vertebra only fuses with the second, forming the odontoid process or dens of the atlas. Posterior arch is very long posterior arch, and it bears a posterior tubercle, which is the remnant or represents the spine of the first cervical vertebra. So as I told you, the upper surface kidney shaped facet, anterior arch as anterior tubercle, and inner surface, as I told you, articulation for the odontoid process. The lateral bars also has a tubercle medially, which is giving attachment to the transverse ligament of atlas. So the transverse ligament will not like this. So the odontoid process will be present at the transverse ligament, which forms your pivot joint. So here the pivot, the central axis of the odontoid process is fixed, whereas the atlas rotates. So thereby what happens, it produces your no movement of the head. So for this reason, what you have is the pivot joint. So the pivot is mainly formed by the odontoid process, the axis, and the arch or the ring of the pivot is mainly formed by the arch of the atlas and the transverse ligament of the atlas. So the transverse ligament mainly helps to hold the odontoid process in its place. So the posterior arch has a posterior tubercle which is rudimentary. So next, what you are able to see here is the second cervical vertebra or the axis vertebra. So mainly how do you identify is by the presence of the odontoid process. Again, the body is absent. It is in the form of odontoid process or the dens of the axis. You call it as the dens of the axis. Anteriorly, we have an articular facet through which it articulates with the similar facet or the inner aspect of the arch of the atlas. Okay. Then posteriorly for articulation with the transverse ligament, that also we have seen the odontoid process. Superior articular facet, you have seen an articular facet which is round, articulates with the similar facet or the inferior aspect of the lateral mass of the atlas. This is mainly the weight bearing facet. Okay, so mainly it is responsible for the weight bearing. Then if you look at the spine, which is very massive, thick spine, and it is bifid. Okay, so the spine is thick and bifid, presence of the odontoid process, and then you have the two superior articular facets which is responsible for the weight bearing. So these are the identification aspects for the second cervical vertebra or the axis vertebra. Transverse process is very much small, and you have the foramen transversorium. The next atypical cervical vertebra is your seventh cervical vertebra or the vertebra prominens, because of its long spine, and actually the long spine is not bifid, no bifid spine, it is fused, the tip of the spine is fused but very long spine as compared to the other cervical, the opposite cervical vertebra. Okay, and it is called as vertebra prominens because the spine can also be palpated at the nape of the neck, lower part, and this vertebra is in transition because it is slowly getting the transition form into the thoracic vertebra. So long and unbifid spine. A transverse process is very large and no anterior tubercle. You have the anterior root costotransverse bar anterior to this side. And see the foramen transversorium. It is very small and sometimes it might be absent, and it does not transmit the vertebral artery. Vertebral artery, the third part of the vertebral artery, passes through the foramen transversorium of the first to sixth cervical vertebra, but not through the seventh cervical vertebra. So only it transmits the plexus of veins. Okay, so that is about the cervical vertebra, and that is all for today. Thank you very much for your patience.